introduce our next speaker. Our next speaker is Dr. Margit Kaufman. She's the director, Institute of Patient Blood Management and Bloodless Medicine and Surgery, Englewood Hospital, Englewood. Dr. Margit Kaufman specializes in the field of anesthesiology, critical care medicine, and patient blood management. She received a Doctor of Medicine degree from University of Medicine and Dentistry, Robert Wood Johnson Medical School, and subsequently completed a residency in anesthesiology. She then pursued a fellowship in critical care management at Icahn School of Medicine at Mount Sinai, during which she developed a particular interest in patient blood management. Her research in this field has focused on optimizing blood utilization in critically ill patients, reducing unnecessary transfusion, and minimizing the risk associated with transfusion. As the medical director of the Institute for Patient Blood Management and Bloodless Medicine and Surgery at Englewood Health, Dr. Kaufman has led numerous initiatives aimed at improving patient outcome through evidence-based blood management practice. Most recently, Dr. Kaufman has created a mobile and web-based app to improve compliance for patient blood management metrics and improve efficiency of the treatment of patients for whom blood transfusion is not an option. Dr. Kaufman is dedicated to advancing the field of patient blood management, improving patient outcome, and promoting safe and effective healthcare practices. Let's make welcome Dr. Margit Kaufman as she takes us in the next topic.
Thank you so much. I really appreciate the warm welcome. Dr. Sara, thank you again for inviting me to speak this year. As for disclosures, I actually just want to be upfront with our audience that I'm not trained by ethicists. And also, I was blessed to have joined a hospital and institution that had kind of worked through a lot of these issues before I'd even arrived. So I want to take today to share with you what some of my thoughts are on how the Institute for Patient Blood Management and Bloodless Medicine in Englewood have used ethics as a framework to provide exceptional patient care. And my last little disclosure is I actually worked overnight tonight. So if I switch some of my words up, I do apologize. So the concept of ethics in healthcare is actually based on the concept of overarching concept of dignity, and that all patients are human and they have this innate right to be valued and receive ethical care and treatment. There's no ands, ifs, and buts about that. And as so many of the phenomenal speakers have spoken about this week, there are some main pillars in medical ethics. There are some people who may add more than these four, but I'm going to focus on these main four and what role they have been played in running of a patient blood management program. We're going to take actually more of a higher up view, a bit farther away from that patient-clinician relationship and focusing more on organizational ethics. So the beneficence, that's the action on focusing what is good for the patient. And then non-malfeasance, what's to avoid harm, that, the do no harm, that main concept. Autonomy, the capacity for a rational individual to make informed and uncoerced decisions. And lastly, justice, which is really concerned that there's equitable distribution of benefits and burdens to individuals within social institutions. But before we dive into the way that ethics guide the patient blood management program, I think we actually have to stop and really kind of maybe broadly define what is a PBM program. And while there might be many variations of this, there needs to be some level of consistency in organizational requirements. Thankfully, SABM has created their standards, which did define a lot of requirements for a patient blood management program. So first of all, it needs to be a formal structured program. You need to identify and have the presence of clinical leaders There has to be this, ongoing creation of policies, procedures, protocols in the area of patient blood management to ensure compliance with institutional standards. And lastly, having a defined mission and vision of these stated values to make sure that the program is continually staying on the track that it was set to do. And again, all this requires ongoing education within multiple levels within an institution. So let's start to go through these ethical concepts and see how are they specific within a patient blood management program or a bloodless medicine program. So the first one, autonomy. That the patient has a right to determine what will and will not happen to them, even if this decision goes against common societal norms. I think the most common way patient's autonomy is really protected is through informed consent process. The patient requires a truthful and complete discussion to determine what they want. Thankfully, Dr. Isbister last year in 2022 published a phenomenal paper discussing specifically the role of informed consent in patient blood management. Healthcare institutions must have a formal process to obtain informed consent. Information that's relevant to the patient must be disclosed. And this is going to be much more on a patient-specific level. So not necessarily what institution has to decide about, but there has to be this encouragement that also competence, how do you define competence, must be ensured, or the process for alternative decision makers. And in the United States, there are specific legal processes for how alternative decision makers are defined. And then comprehension also has to be confirmed, right? We have to make sure that the patient is actually understanding what they've been told. And most importantly, voluntariness of the patient to accept or decline treatment options has to be protected within the institution. In 2022, leaders in patient blood management, many who've spoken this week and previously at BMSS, wrote the global definition of patient blood management, and specifically included was the concept of evidence-based medicine in this global definition. So what, is evidence-based medicine? How's it been defined? So it's really not just solely focused on the research and evidence, or data or proof, but also has to be melded with the patient's values and preferences. So it shows how key ethical components of modern medicine and a patient blood management program must include patient engagement, shared decision-making, and informed consent. So how is this process of informed consent being done in a patient blood management program? So in our program, patients who want to enroll in our bloodless program have to have a formal process where they receive education in their appropriate language on the educational level that helps them with their understanding. And they are able to complete documentation of what their wishes are, what their choices are. This process also can create a level of justice as well, because we are ensuring that our patients have the same conversations, consistent information, they're given time to make the decisions, and they're not pressured as well. Moving on to our second ethical pillar, beneficence. An organization has to focus on doing or promoting good things for patients. I think we need to define what is good for a patient, though. It's probably best to actually use a holistic view of not just that the patient, focusing on the patient's physical well-being, but also their emotional, social, and spiritual well-being. So how does an institution focus broadly on promoting good and making it easier to promote good for patients? An institution needs to fund and support many different areas in order to promote goodness in their patient level of care. So let's dive into some specific examples. So policies and procedures. Having a formal process that allows clinicians to know what are the expected methods of treatment, where is the evidence coming from, and what are the known risks. Right? In addition, this also plays a role in justice for patients because we can ensure fair and equal treatment being offered to patients with similar health conditions. A patient still has the right to accept or decline the offered treatment, though. So some examples in our program, policies or procedures that we've included is severe anemia management when patients, have signs of end organ hypoxia or dysoxia. How do we reverse anticoagulants? What are the standards for pre-op anemia that we have defined for our institution? Culture. Building culture is not simple. Anyone in a leadership role can tell you that, hands down. And I'm the first one to admit that I was blessed to have arrived in an institution that already had a very strong culture focused on the ethical care of all patients. But specifically in our Bloodless program, this is a hospital-wide effort across all specialties. It doesn't matter if it's the dietitian, the nursing staff, the respiratory therapist, the physician at bedside, nursing. It does not exist in a silo, our commitment to the ethical care, what's up front and center every single day. Well, ethics and money don't always come together in discussions. Healthcare institutions do have limited resources. We're all extremely aware of that. So when choosing where resources are spent, using beneficence is a very good concept to help define where resources should be provide the best for good for patients or to promote good. So just some examples in our program, if you look on the left side, these are some of the amazing people who are the dedicated staff that work in our Bloodless department who are paid to work for us. Or in the middle, an example of equipment that the hospital invests in to help us maintain cutting edge practice in areas of patient blood management. Or even lastly, this forward-focusing view. It's a screenshot of a mobile and web-based app that the hospital funded through the creation of a physician innovation grant. And this app has actually allowed us to improve our compliance with our patient blood management protocols. Also ensuring that our clinicians and our patients continue to receive education. So on the left side, we have our regularly scheduled lectures and educational sessions in so many different areas within the hospital. This is part of our functioning of our patient blood management program. And on the right, here's these screenshots of some of our multiple free community educational programs that we provide in more than one language to help our patients keep up to date and educate about their own health and well-being. Moving on to our third ethical pillar, avoidance of harm. We can't avoid all harm, right? Every day we have to stick patients with needles. We give them medications that have side effects so they get dizzy or nauseous. But what are some ways an institution can continue to strive to reduce harm? We have to have research to gain more data and evidence for the role or elimination of treatments that can harm patients. We also have to have an ethical requirement to be honest and upfront with our patients when we lack data about specific areas. So what are some of the steps that programs can take to reduce harm? They need to collect data and examine it on a routine basis. They're using that internal data. They should have ongoing quality improvement projects that need to be initiated. And then when answers are challenging to find, then that means that's the areas of research that need to be further worked out. One method that we use to focus on harm reduction within the institution is our patient blood management committee. So without a strong patient blood management program, it's really hard to have a strong bloodless program. And part of our patient blood management program is this committee made up of multiple different types of clinicians, physicians, nurse practitioners, physician assistants, trainees, pharmacists. This committee is responsible for writing, reviewing, and updating protocols and policies. They consistently review data compiled by our informatics team and identify areas of improvement for our institution. Then they set up programs for improvement and evaluate the effectiveness of them. They also review specific cases where treatment really fell outside our hospital guidelines and offer ongoing education and corrective action for those clinicians. And for the last pillar, justice. A patient blood management program has to ensure that patients are treated justly, fairly, and equally. Discrimination has to be prohibited. So how does an institution ensure justice? Probably the main area, and there are many different types, subsections of justice, is probably procedural justice. When decisions are being made, is there a focus on dignity, right? Trust, consistency, lack of bias. And these are, when overlying decisions are being made within an institution. So when clinicians or patients, though, have a fear that there's been a lack of justice, there also needs to be a way for patients to raise this issue. So defining clear expectations for the behavior of both clinicians and patients. And also having these abilities for patients to have concerns raised. So for us in our institution, we have the Department of Patient and Family Engagement. Other institutions might have ombudsman or things like that. And lastly, the talk also wanted to encompass this concept of compassion. It can be defined as as you know, our previous speaker said, a strong feeling of sympathy for people or animals who are suffering and the desire to help them. So the first thing that I thought about when I thought about compassion was how we use language in our institution. And this is something that we work on with training our residents with the Breaking Bad, or when I do onboarding with new clinicians joining, is we really we point out and we practice some of the language that we think focusing on help that show patients that we have this desire to help them. So, one of the examples, we really moved away from using the terms such as refuse, because it puts the patient in the light of being against the clinicians somehow. Instead, decline, which incorporates that there was thought and effort on the side of the patients, that they made a decision that they believe is best for them, and really move away from that paternalistic view to more of a patient-centered view. Another example is when the patient is severely anemic and suffering from a low hemoglobin. How do we discuss this with the patient? We've all heard that there have been horrible methods of bullying and threatening, but what if instead we continue to focus on the ethical concepts, such as autonomy? I'll say something like, you have shared that blood transfusions are not an option for you, or informed consent, right? This is a clinical point where I would be offering someone who accepted blood transfusion, right? And I give the patient the relevant information, and so that they know. Beneficence, since transfusion is not an option for you, let me tell you what I can offer you, such as IV iron, erythropoietin stimulating agents, ICU admission. And then if you like to discuss other options, I give that opportunity to the patient. So I ensure justice as well. So I thought maybe to wrap it up, we use two examples to see how these larger concepts apply. So a 55-year-old male is diagnosed with a large undifferentiated sarcoma involving the right kidney, parts of duodenum, jejunum. It was invading the renal vein into the IVC in the right atrium. The patient was seen at a hospital without a bloodless medicine program, and blood transfusion was not an option for the patient. And the patient was informed that they need to seek care elsewhere. Is this ethical? So autonomy, the patient has the right to decline transfusion. That was being protected and respected. Beneficence, the acknowledgement that this institution might not have the knowledge or expertise to provide good to the patient. And non-malfeasance, they're not offering treatment that they're not equipped to do. So they're avoiding harm. Justice, honestly, I'm not so sure. Are they offering equal treatment? Probably yes, they're offering treatment with blood transfusions, but I actually think justice would be more appropriate if it was made that the hospital helped the patient find an accepting institution which could fully meet their needs. And then the second example, a 78-year-old on anticoagulation for atrial fibrillation and no gastric ulcer presents to the emergency department at 1 o'clock in the morning after vomiting bright red blood 3 times. She's tachycardic and has a low blood pressure, and she's seen in a hospital without a bloodless medicine program, and blood transfusion is not an option for this patient. And the patient was informed that she needs to seek care elsewhere. Is this ethical? Well, let's go through them again. Autonomy, the patient's right to decline transfusion is being respected. Beneficence, I don't think so. The good for this patient is immediate treatment to stop bleeding. Non-malfeasance, that's probably not being met either, because they're causing delay in treatment for this patient by sending an unstable, actively bleeding patient to be transported to another facility. And justice, are they offering equal treatment? No. A patient with active bleeding needed to be stopped immediately. I wouldn't be remiss if I didn't always take the opportunity to thank my wonderful mentors and people who support me on every day, the ICU physicians, anesthesiologists and CRNAs, and the wonderful staff in the Bloodless Medicine Department, and of course the Patient Blood Management Committee, who I enjoy working with on a regular basis. And as always, our institute is here to help, and my email address is there, and we look forward to hearing the other speakers.
Thank you, Dr. Kaufman. At this time,